All right, well, let's get started. It's 2:02. We got more than 40 folks on the webinar. It's really awesome to see all of you in attendance. Um, Again, my name is Keith Coker. I am an emergency physician at the University of Michigan. I'm the medical director of the Michigan Emergency Department Improvement Collaborative. And if you've been on these prior webinars, you know that this is a learning series focused on providing education, advocacy for implementation, specifically about HIV screening programs in emergency departments. And we've got a partnership with the Michigan Department of Health and Human Services to support this work across the state. And one of the things that we think is beneficial in supporting that work is to host these seminar series where we have speakers come in and talk about a rotating set of topics that we think are important here. And so we've got a great speaker today, and I'll make a little introduction of Monique in a bit. Again, just a reminder here about completing the survey. The QR code is right here, and there's a link in the chat. A couple other things. Ordinarily, we provide CME for these webinars. Unfortunately for this one, it came together a little bit more last minute, so we weren't able to meet all of the administrative requirements to provide CME. Hope that doesn't detract from the talk that we've got today, and certainly something that we'll continue to provide as we're able to in the future. And then finally, we really would like, to the extent that you guys want to participate, some questions and answers. We'll be monitoring the chat, so feel free to put in questions in the chat. We'll have time to take direct questions as well. We've got a lot of opportunities to spend as much time probably as we want on these kind of questions. So definitely don't be shy to ask. So we're going to hear from Monique Rucker today. She works for Gilead and has for a long time supported HIV screening implementation programs. One of the things too that we've heard about in the past is some more information about the types of tests that are used to screen and confirm HIV, and we'll have some information about that during today's talk as well. So Monique, I'm going to hand things over to you. So if you're ready, you have the floor.
Hi, everyone. Let me just share my screen and make sure I am.
Things look good from my end.
All right, perfect.
Oh, we're now seeing your notes. So I think
Oh,
what
you
you had
are?
before, yeah.
Okay.
So if you want to switch to maybe presentation mode.
Should be. Okay, hold on. Every Zoom is different.
Yeah, you're doing good.
Um,
Looks good. Yeah, that looks good.
okay, but now I can't see my notes, but
Sorry.
see them now?
No.
Oh, perfect. Okay. Hi, everyone. I'm Monique Rucker. As Keith mentioned, I'm the regional director for Gilead's Focus program. I cover several states within the Midwest, including Michigan. Been working in Michigan since the beginning of the work that I started. I'm going to be sharing information about the evolution of the Focus program. And I think it's always important to tell people I used to be a Focus partner in Chicago and it was actually a health system that had two different hospitals, countless outpatient clinics. We had two level one trauma EDs. I wrote the original Focus proposal for the work and thought, oh, this can't be too difficult to launch screening in these emergency departments. And little did I know, yep, it was going to be a big challenge. But I really enjoyed it. We ended up changing the law within Illinois to allow opt-out testing to occur. It was actually illegal at the time for it to occur. And so, due to feedback from my risk managers, we along with others within Chicago and Illinois, helped to change the law to allow opt-out testing to occur both within my health system as well as other settings around Illinois. Um, then I joined Gilead and have been working there for 10 years this week, which is crazy. Never thought it was going to be that long, and have worked with several organizations within Michigan to do this work. And so, that's what I'll talk about. As Keith mentioned, I'm pretty casual. I have plenty of content. I can either deliver it through these slides or I can do it by responding to things that you're interested in. Please stop me, insert things in the chat. As he mentioned, this is intended to be really interactive. So I'll go ahead and move on. We always have to include a disclaimer with our work because we're firewalled from the commercial interests of Gilead. And you can read this, at your leisure. We'll be sharing these slides, but our funding only supports HIV, Hep C, and Hep B screening and linkage to a first medical appointment. And so the awards that we give are not supposed to cover anything past that first medical appointment. Obviously, we know that anyone that we're working with cares about the whole patient and the entire spectrum of services that they have to receive. It's just that our funding only covers a portion of that. So I think that that's important to mention. This is a map of where we're located. We're in 178 partnerships across the United States, Spain, and Portugal. These partnerships are set up 1 year at a time. They're mostly in hospitals, as you can see there on the right. 66% of our partnerships are in emergency departments, which is, the focus of this webinar series. We're also in other settings as well, correctional settings, syringe access programs, pretty much anywhere individuals could potentially be screened for HIV. We're in every EHE county, and all of our partnerships include HIV screening to some degree. So that's an overview of kind of our presence, around the country and like I said, overseas. This is an overview of our timeline. The CDC released routine screening recommendations in 2006. Several years later, there were individuals at Gilead as well as across the country who were trying to figure out, how do you operationalize these recommendations? The recommendations were made, but no one necessarily had figured out, well, how do you actually do this work? And so we piloted the implementation of a model in 3 different cities around the country. And the model that we have today came from the clinicians and the staff that were part of those pilot sites. So it did not come from Gilead. It came from, folks in the field, which it should. Everything we do is driven by the CDC's recommendations. So first there were recommendations for HIV. And then after that, there's been subsequent recommendations for Hep C and Hep B, which I'm not covering today. What we've done is we layer on the application of our model to different disease states, depending on the recommendations that are out there. And we pay attention to both, as I mentioned, the CDC's recommendations, but also the USPSTF recommendations, and really work with partners to implement them based on what's being suggested and recommended. In Focus, we take a customized approach. I think we can't state that enough. This is a very non-traditional funding stream. I'm not a program officer. I'm considered a regional lead. I literally am embedded in the state that I work with. I work within 5 different states. We approach prospective partners typically either from recommendation of a local or state health department, or because we might have interests ourselves. When we work with health departments, they may say to us, we recently lost funding for this particular agency that's providing great work and has this unmet need. Or they may say, we've always wanted to work in this neck of the woods, but we don't have the funding for it, or the federal funding we have only covers certain zip codes. Could you cover this part of the state? So our engagement with the health department is super duper important, as well as looking at the epidemiology and making sure that it supports a need for the work, which if the health department is making a recommendation, it would. We feel like the success of the program is driven by the regional lead, which is what I am. There's 13 other individuals that are my counterparts across the country, as well as in Spain and Portugal. And then our relationship with whomever the key contacts are within, for example, the emergency department. There's usually a program staff person and a clinician that we're working very closely with to implement this. And then internally, they're having the conversations that they need to have. We really try to leverage learnings from other partnerships. This is, again, I think, how we differentiate ourselves. So we really don't want our partners to just keep information to themselves and just put it in a report at 6 months or 1 year. We would love for them to jump on the phone or, talk at a conference and share what they're learning, share like this didn't work, or oh my gosh, we did this and this worked amazingly. Maybe it was in this particular EMR that we made this change, but you could totally adapt it in this other EMR. And so that's what focus is all about is iterating and kind of taking one approach and adapting it to a new setting. Since 2010, we partnered with more than 500 healthcare institutions and as well as CBOs, and they've performed over 23 million HIV, Hep C, and Hep B tests. The model that I mentioned is there on the right. We call it TEST. It stands for the T is looking at the workflow and figuring out how to integrate testing into the workflow. So for emergency departments, typically looking at triage and figuring out, where's the best place for that screening prompt to go, where would the results be routed back, how would the lab order, be populated, et cetera. Looking at the EMR, that's the next part, and figuring out, since this is relied upon to provide services, how can we minimally adapt it to support the screening and linkage? We don't want 5, 6, 7, 8 clicks, for a clinician to have to do. We'd love 1 to 2 clicks to be able to, um, order labs and send them off for someone who's eligible to be tested. And so we share through webinars, as well as other materials, how people have modified Epic or Cerner or some other EMR, and we get partners to kind of provide TA to each other, or we do that ourselves as regional leads. I'm trying to think of what else I want to cover with this. Actually, I'll cover that later. So that's test. The other two pieces of the model are looking at what policies need to be either implemented or changed. It's important that there's a policy, that there's a culture towards conducting the screening and linkage, and then figuring out who needs to be trained, what staff need to be trained, what do they need to be trained on, setting up data reports and looking at them and conducting CQI or continuous quality improvement and figuring out, well, what's working well and what's not working so well. And how can our data kind of inform that? So the last thing we want to do is look at our data like 6 months down the line. We'd love when people start implementing these programs, looking at them and looking at the data literally every day and having that relationship with the IT department where they can get a daily report or weekly report and see like how well are we actually screening in the eligible patient population. So our model and the way it's set up really is intended to address multiple epidemics at one time. This is something that some partners started to do. Not all, but more and more are using one lab vial to be able to test for multiple diseases at one time. We consider it a syndemic approach. And it's something that is a priority, at different levels of government. It's supported by the U.S. National HIV/AIDS Strategy. And it's something that we've learned through our partners. We consider it, implementation science that's taught us the most efficient way to actually conduct this screening. So just wanted to be able to show you that. This slide is pretty busy, but it gives you a sense of kind of what hospitals are faced with when trying to do this work. There are a lot of approvals that have to take place to be able to conduct screening and linkage. And so myself as a regional lead, what we do is we work with whomever our contact is, and it might vary depending on what we're focused on to do what we consider change management. We're looking at, again, what policies are in place to be able to support this work or need to be in place. Some people say, well, there's not a policy, we're not going to do this work. Okay, so let's work to develop a policy, looking at the workflows, figuring out, again, what modifications need to be made that are related to IT, figuring out how to integrate any staff who are hired, for example, navigators into existing meetings, getting them access to the EMR to be able to write patient care notes. And so that's some of what we do. If you look on the right, these are just kind of examples of some different committees that someone may have to go and present before to be able to convince an institution to do this work. And so we might work with them to be able to request to get on the agenda. Sometimes it takes months, maybe a year to even get on the agenda, work with them to be prepared once the meeting has actually occurred. And a lot of times we are connecting partners to each other. Maybe someone has to go, before an EMR modification committee or an IRB is required. What we really try to do is leverage the learnings between, from institution to institution so that people do not have to reinvent the wheel. And what the last thing that I would say about this is that these meetings that occur, sometimes I work with institutions and they do all of this before they actually even put in an application to focus. And then sometimes they want me to be with them doing all this after they've been awarded. So again, we've really tried to provide a customized approach. Sometimes, people want to do things on their own, but they just want you to help inform what they're doing. We're totally fine with that. We're going to work with an institution or emergency department, however it's best for them based on the culture that they have set forth within their institution. I'm going to switch to focus on the lab for a moment, given its importance, to doing all the screening. As we know, you could utilize your internal lab, or there may be external labs or external labs that are used. You might decide to use a commercial lab. Or the state, you may be processing lab specimens through the state. What we've set up is to have Dr. Samuel, who's a laboratorian at Henry Ford, which is one of our partners, talk about some of the considerations that have to be made when conducting screening for any emergency department that may be doing so. So I'm going to go ahead and play this short video.
Hello, my name is Dr. Leonard Samuel. I'm the division head for clinical microbiology for Henry Ford Health, and as such, I oversee HIV testing for our health system. So I'm going to go over some of the specimen requirements for HIV screening. In our lab, we typically do the 4th generation HIV antibody antigen combo test. You may be using the 5th generation in your institution. Both of the tests function on the same principle with slight differences. For that, we typically need one gold top tube with a minimum of 1 ml. But that's really just the first step of testing. If that HIV antigen antibody screen is positive, then in our lab, it would automatically reflex to an HIV-1-2 antibody differentiation assay. And that is an important step because that confirms the initial screening result. We do know that a very small proportion of patients may test false positive with the HIV screening assay in our setting, and it's typically less than 1%. Our data, it's about 0.6 to 0.7% false positive rate. That's the norm, unfortunately. And one thing you need to be cognizant about, because those false positives absolutely need to be confirmed before they are communicated to the patient. So it may cause some unnecessary anxiety when patients may sort of see the screening results. I think it's important to qualify that that test result needs to be confirmed by the HIV-1-2 differentiation assay. And that does not require an additional tube. In our lab, at least, and I would confirm this with your local lab, you can use the same gold top tube to do both the screening assay and the HIV-1-2 confirmation. Now, in a patient where you are suspecting recent exposure or infection, and you have a positive HIV antigen antibody screen, but a negative HIV confirmatory, a 1-2 confirmatory test, you may still want to consider the HIV RNA test. And your lab may or may not reflex the test, but we cannot reflex off of that gold top 2. So you do need a separate EDTA tube with about 3 ml of blood. So it does take a lot more blood than the screening assay. You do need a little more blood and a different tube to do the HIV-1 RNA. So that would be necessary if someone has confirmed HIV and you want to check their viral loads, or if someone has a recent exposure and you're concerned about a false negative confirmatory test, which is very uncommon, but it can happen. So as I mentioned, so basically the gold top for the screening test and for the confirmatory HIV 1-2, and then separate EDTA tube with a minimum of 3 ml of blood for the HIV RNA test. False positives, as I mentioned, less than 1%, and this is why you do need the HIV 1-2 confirmation and ideally also the HIV RNA. A lot of labs will have a stat HIV testing option. So this in our institution, and again, I would encourage you to confirm this with your institution, you would have a separate order that is specifically intended for stat HIV screens. This might be in the case of, let's say, an employee needle stick exposure, we need to test a source patient, or in the case of a pregnant patient where you really want to confirm that result and avoid unnecessary anxiety due to delays in testing. So these are the testing options that are available in most institutions. This is pretty common across most places, but I would encourage you to confirm what your lab is doing and what their specific requirements are. Thank you.
Okay, so I have built in time for questions or comments. I see one thing in the chat. I can't read it, but any thoughts that people have or questions, I can go on, or we can pause for a moment.
Yeah, we should definitely pause and see if there are questions. The comment in the chat was, I think, referring to the map that you showed, saying that maybe you've got some activity in Columbia, Missouri. I don't know if this individual has connections or roots to Missouri, but
have I shown them? Oh, back here.
Yeah.
Yes. I'll just leave that up.
Sure.
I don't cover Missouri. Otherwise, I'd be happy to talk about it.
Yeah. Well, I do have a question, Monique, while we're waiting for others who may have others. You have so much experience over the years in so many different settings around how to do this work. And you mentioned like a host of barriers and facilitators to really you really have to overcome. How would you what's your advice about just getting started? Like, how would you get started if you were interested in building a program in HIV screening in an emergency department?
I think first I would take a pulse on the interest internally with the nurses and the physicians, and just see, how do they feel? Because I think that buy-in is so important. Without them, it's not going to get done. And I would check their pulse, but then also try to educate them. A lot of times, and I did this when I was a partner, you can share the local epidemiology in a very bite-sized way that people care about. So not necessarily statewide, but like what's going on right there in that community. How many tests have been done in the past? How many people have been diagnosed? Share a story about someone who was diagnosed and celebrate that clinician who ordered that test. And then share what happened. What did that story of connecting them to care look like? I think a lot of times people are kind of okay about the testing, but they get nervous around that follow-up and what we call linkage to care. So I would just kind of start the conversation and then get a sense of like, where are the pain points? Do people even buy into the fact that there could be a potential role that the emergency department could play doing this? Is there an acceptance that people are coming into the ED who have undiagnosed HIV, but also possibly who are out of care? So I would try to like check the pulse and then meet people where they're at and then slowly educate, but you can't beat people over the head. I mean, it could take months. It could take years. Food is always really good, to gather people, talk things through. Also do one-on-one, figure out like who really are the key influencers within the emergency department. It may not even be anyone in leadership. Like getting to those people, understanding what their concerns are, and then slowly kind of trying to address them, not beat them over the head, but like figure out what their blind spots are, or what their very valid concerns are, and then working to educate and then kind of building from there. So those are just some of the things, Keith, that
Mhm.
I'm thinking of I would do to start.
Yeah, that all sounds like hard fought wisdom.
And don't give up and be positive, because you're
Mhm.
going to get a lot of pushback. This work is not for people who want an easy yes. I think it's important, last thing I'll say, just keep the patient in mind. Think of the person who is coming in and they're assuming in a lot of cases, especially if labs are being drawn, that they're being tested for HIV, especially in a state where there's opt-out testing that's permitted. So sometimes it's not that as difficult as people make it in their head. They might already think they're being tested. But you certainly want to really think hard about having someone come in and out and they're not tested and you had an opportunity to reassure them and let them know that they're negative or connect them to care if they're positive. It goes both ways. It's a status neutral, approach.
That's really great. Are there other questions from the group? There was definitely a comment to you, Monique, saying that was really helpful and thank
Oh,
you.
good. Thanks, Caitlin. I can keep it coming. You can tell me that was a great question, Keith. Any others? Anything that people are challenged with, you know, I'll keep going. Well, I'll walk through a few more slides and probably what I'll do is I'll just probably walk through one slide on the impact. Something else came in and then I'll jump to what it looks like when we set up our partnerships. And then kind of see what other questions come up for people. Let me see if I can advance. Okay. Do you see this slide?
Yep.
This is another map slide. It gives you a sense of the impact that partners are making across the United States. What we do is we work to try to get data from local and state epidemiologists on the number of diagnoses that are made in a particular city or maybe just by a particular partner within a city or within a state. And we really value having access to this. This is anonymized data. It's also really great for our partners to be able to have. This is the type of thing, for example, Keith, that someone might use internally to be able to make a case. We've had instances where people have been running programs for several years, and then the leadership changes and they say, we're not doing this screening anymore. And to be able to go and say, just to let you know, our local health department let us know that we're diagnosing 11%, of the HIV within the county. I mean, that's kind of a mic drop. That makes people stop and think. And so this data is really, really helpful. We have an example here in Michigan. Since 2020, a Michigan-based focus partner has been the leading diagnoser of HIV in both the state and the city of Detroit. So I'll let you all read that on your own, but these are some different cities and states and some data that comes from them. I cover Chicago, where 35% of all new HIV infections were made by active focus partners. And when we looked at all of the partners that have ever existed, which we include like what we call graduated partners, they diagnose over half the infection in the city. So it really is just speaking to the impact, that these screening programs are making. One of the things that we really encourage from our partners is to disseminate or share information. It could be in a statewide conference, which is very important, or a local conference, or it could be a mega national or international conference. We can support if they're accepted to present a poster or do an oral presentation. We can support that work. And so this is just some examples on the right of really some amazing work that has come out of these partnerships. And this is what people look to try to build their programs. Again, Keith, going back to your question, looking at these publications, looking at the methods section and figuring out, well, like, how did they set their program up? Maybe looking at publications in your particular city or your particular state or in a similar type of institution. And really getting a sense of like, well, how did they build their program and what do we want to kind of take from that? So I just wanted to share that. This is an example of an abstract that we just presented at CROI. On most occasions, partners lead their own dissemination, but earlier this year, we actually presented our very first abstract, which we were really excited to do. It's called Detection and Linkage of People Living with HIV who are out of care in 94 emergency departments across the US. And again, that was at the conference on retroviruses and opportunistic infections, took place in San Francisco. So we analyzed focus partner data across 94 EDs from 2021 to 2023. And there were over 1.5 million HIV tests that they conducted. Among those patients who were identified to have HIV during that particular time period, 39% were previously diagnosed with HIV and were out of care. 67% of that group ultimately was linked back to care. And we felt like this analysis was really important because it supported what we really have seen for years, that routine screening identifies individuals with new infection, but also those who are out of care. And when you think about a lot of these individuals are coming back regularly into the emergency department, and they are coming in for multiple reasons. And if you're not able to either test them or figure out whether or not they have a disease that's being untreated, you could be potentially increasing the amount of readmissions, for example, that your emergency department might have. That might be kind of a ding financially, to your emergency department. So this is a lot of the work that we do, that our partners lead, is really looking at their data and thinking about what are the implications, for this work, for this screening and linkage work. I can stop for another moment before I cover this last section.
Yeah, for sure. Definitely, it's the moment folks have questions for Monique.
I know people are not this shy.
Well, I have another question.
Okay.
While we're waiting. So I heard you say this, I think, a bit already. I think probably one of the biggest fears or concerns and therefore barriers to implementing these kind of programs, I think in the emergency department in particular, is the linkage to care problem. And some sense of both like being overwhelmed with positive tests and then not being able to guide or link people kind of appropriately to the next step of care, and kind of being worried about the responsibility and wanting to do right by the patient, but also being uncertain about being able to solve that. Do you have any like advice or recommendations about how to begin to kind of work through that linkage problem?
Yeah, I think it's a valid concern, and as you mentioned, it's raised all the time. I think you first start with the infectious disease clinic, who has so much experience caring for individuals, whether or not there's testing taking place or not, if there's an infectious disease clinic affiliated with that health system, that's the place to start, to understand, are there clinicians that could support the linkage? They could come to the ED and do a consult in real time, or, if somebody ends up coming back. In our case, with our program, we will support the hiring of a navigator. Someone whose job literally is just to follow up with individuals who are diagnosed or found to be out of care. Sometimes there's social workers or case managers that are already within the emergency department, and they're following up on other individuals. And there could be an opportunity to see if you could add a follow-up of individuals diagnosed with HIV to that caseload. They already have amazing experience assessing the needs, linking individuals to a whole host of services to address those needs. Is there bandwidth, for them to do that, for someone living with HIV or just diagnosed with HIV? I think that, in the cases where an ED hires a navigator, what we've seen is that after a couple of years, the clinicians start saying, you know what, that's not that challenging. Like, if I can kind of get my script down, if I can shadow the navigator a little bit, which sometimes seems odd, like, wait a second, a clinician is going to shadow a navigator. But yeah, that's exactly what happens. They have the language to use to appropriately and comfortably talk to someone. Slowly we see that the clinicians start taking on some of that experience. Some still say, that's okay, I'm happy to test, I do not want to talk to any patients. And some say, you know what, I think I can do it, especially when they diagnose someone and they have that success of seeing them get into care. I think that really sparks some enthusiasm, both for that clinician as well as like their peer clinicians. And last thing I would say is, I think the most successful programs kind of have some of everything going on. So you might have a nurse or a physician, or a pharmacist, or from the infectious disease clinic that's helping. You might also have a social worker. You might also have an ED clinician. So it doesn't have to just be one set of individuals. And the other thing we do is we work to set up getting the results routed, not just to the ordering clinician, but to anyone that would be potentially responsible for following up with the patient, so that you don't have to go and like dig in the EMR, but you can get the results sent into like your email inbox. There's examples where you could get a text message. So just trying to do things where ideally you could follow up with the person while they're there still in the ED before they're discharged. But if not, possibly doing a phone call, which at one time seemed kind of like, wait a second, you're going to follow up with individuals over the phone. But people, especially sometimes young people, prefer that. So you have to kind of figure out like, well, what's the comfort level of the person doing the linkage, and what is the comfort level of the patient? And it could be a combination of approaches. It could be the phone, but it could also be, bringing them back in. So does that answer your question, Keith?
Oh, for sure. There's so many good tips in there.
Okay, good.
And I definitely sort of understand what you're saying. You start one place, things evolve. Turns out it may be not so hard for clinicians in the moment to kind of learn the right kind of scripting. And certainly there are lots of ways to solve this. It's great to hear all the experiences that you're describing.
Okay. Well, I'm gonna just cover two last little slides, and then we just really can open it up. I want to just talk about how I get started for anyone who might be on the call who's like, we might be interested in partnering with Focus. I mean, there's no pressure either way. But as I mentioned, it's based on a conversation and kind of having mutual interest. And then we don't have an RFP, but we would invite, someone to apply, for funding. I put this slide back up because, it's a regional lead that would be working with the individual in Michigan. That would be myself. And essentially, we think about this model and then start to think about, well, where are there things that you're already doing, pieces of this model where it might be in place, and where are the gaps? We sometimes work with agencies and they already have an EMR modification in place, but maybe they don't have a custom report to be able to see like how well that EMR is working. Whatever the situation is, we kind of use this model and then think about, the organization and the program as a whole, and then try to think through like, well, what would it take to make a program successful? And then another thing that's very different is I work hand in hand with the particular agency to develop the proposal. We have an executive summary that's 1 page that has to be written. There's an online proposal that accompanies that, as well as a budget. And so, I help kind of frame based on what it is that's being proposed exactly, how the program would be set up. This last side I'll go through is really important. It kind of speaks to a lot of the cost sharing that we do. And in particular in Michigan, almost every single partnership we've set up, we've had some sort of cost sharing with the state. We're really fortunate to have been able to do that. Examples of sharing costs. So we're talking about there's going to be a larger budget. Let me back up for a moment and just kind of talk about that. A typical budget might have, some clinician time. We have to limit that because of some regulations. So we can support up to 20% of a clinician who is involved with, aspects of the program, typically on a very high level, executive level. Maybe they're the ones that are shepherding approvals, through the health system. They're the ones, attending those committees, that I mentioned. Typically in a first year partnership, there would be a program manager or program director full-time that we suggest to be hired. Or it could be a half-time. Maybe they're working on another program and we can cover 50% of their time. I mentioned navigators, we can cover, we kind of figure out how many people do you think you're going to diagnose or identify as out of care that are going to kind of be on your caseload, so to speak, and then make a recommendation of how many navigators might be needed. So it might be that we're supporting one full navigator. Oh, and then maybe the ED has an internal social worker that they're going to also dedicate to this effort. So that's just some I guess different examples of how the budget is set up. We can support a lot of things. We cannot support medication, we cannot support incentives, but we really try to build the budget based on what the budgetary needs are, of the program. A lot of times, as I mentioned, we try to do cost sharing with the health department. In some jurisdictions, there's EHE funds that are used to, that are complementary to what we're supporting. So maybe half the cost of the navigators is covered by EHE funds, and then we're covering the other costs. Sometimes the state lab may cover the processing of a lab specimen, and maybe we're covering the cost of all the laboratory supplies, for example. It really just kind of depends on the organization, depends on, what the state or local or federal government can do. And we just kind of go from there. That's super high level. I'm happy to talk in depth offline or here in the webinar more. But those are some of the things that we do to build our budgets and build the actual proposal. The entire process probably takes a couple of months from like the proposal to the award if successful. So it's unlike a lot of government programs. You're not looking at like 6 to 9 months, a year down the line. You're looking at, within several months, we can, launch the partnership. And there is also an agreement that we ask the agency to review and sign. And sometimes there is some back and forth that we have to do between attorneys, but we typically are able to form some agreement. That's it in terms of all my content. I'm going to stop. Any other questions that you all might have, or I'd love to just hear your general thoughts, success stories, anything you're challenged with.
Well, there's a couple posts in the chat. One
Okay.
is, I think, um, and sorry if I get your name wrong, Caitlin Wolf in Columbia, Missouri. Sounds like she's working on HIV screening programs and maybe, focuses on opportunity for you, Caitlin. I don't know. There is this kind of long comment post from, apologize again if I get your name wrong, Dion Ragosi in Berrien County. And Dion, are you able to come off mute, maybe say a
Hi.
little bit because you're bringing up a barrier here, that
Um,
maybe we
well,
can talk
I
about.
had to, hi, good afternoon, everybody. I went back to my most recent email with Dr. Byer, who is our medical director, because he's also an ER doctor here locally with Corewell Health. And I had to go back to his last email correspondence, but with what I mentioned, he's working with his senior compliance liaison officer and a health risk leader, and a legal consult was recommended. And I don't know if I typed that legislature in there correctly. If I didn't, I just thought I could follow up with Samantha after this call today. But it just, I mean, he's doing everything he can, to advocate for this. And then I have a couple of community health workers who are fantastic and ready to jump in and help at the ER when these diagnoses come in. And we also work closely with our nurse practitioner, Emily Delmont, who is local as well. So anyway, I just feel like there's a lot of red tape. I don't know if I'm saying that right. And we're
Yeah, I
just
mean,
taking it a day at a time, and we continue to hop on meetings and trying to coordinate these efforts. And like it's exciting, but also can be frustrating at the same time. We're just taking this a day at a time. So.
well, I appreciate your advocacy and your work, and definitely following up with us and Sam specifically. We can definitely, I think, probably help in this regard because the link is broken. It doesn't at least work for me. So I'm not sure which of these
If,
public health codes you're talking about. But we've certainly had some conversations directly with the Michigan Department of Health and Human Services about specifically how to interpret the public health code. And definitely there's some things in there that may make an emergency department pause a little bit around providing quote counseling to patients and what does that exactly mean, and some of the linkage to care challenges, and exactly what is a responsibility on the reporting side to the health department, what exactly does that have to look like. So definitely we can help with that. And Monique, I don't know if you've got some more things you can add.
sure. I think it just that link had a period on it, so I took the period off and then was able
Oh,
to see
okay.
the
Yep.
statute. First of all, I feel your pain. And I would say, I mean, that's exactly like the type of work that we end up doing is literally coaching individuals on whatever the particular concern is in a law, and assuring, coming up for evidence to support why the screening or linkage, the way that the emergency department wants to do it is lawful. But you do have to be responsive and have to be patient, and think about these risk managers. Their number one goal is to protect the agency and to make sure that they're decreasing risk. So they have to feel comfortable. I have gotten on calls. I'm happy to do that and hear the concerns and kind of talk through. You could also email me directly and you can let me know exactly what area they're concerned with, and I can kind of, see if I can give you some ways to troubleshoot that situation. using the health department, sometimes is a good way to get the risk manager to understand that, MDHHS is actually behind this. They are supportive of doing this work. And perhaps I'm not trying to take the time of anyone at the state who is very busy, but even just making that statement, perhaps that could reassure individuals, but typically it requires some work. And typically, that, for example, may be where a clinician could play a role in having a conversation, with someone who's in that department. Usually there's one maybe attorney that might be comfortable, and then maybe it's usually only one or two that's uncomfortable, but maybe others are not comfortable. And so it's about appropriately, kind of creating a way to have those individuals engage with each other so that the concerns are addressed, because you don't want to start screening and then someone put the kibosh and just completely stop everything. So I think it's important to air out the concerns, but then also to bring out there's also risk in not testing. There is risk in someone coming in, again, not being tested. They potentially have evidence that they've been in and out of the emergency department 10, 15 times and they were never tested. And now, unfortunately, they've progressed to, maybe an AIDS diagnosis. And what role, I mean, this is extreme, but, what role did the health system play in not testing someone when the law allowed for it, and then that person had advanced disease? So I think a lot of times risk is only thought about on one side, but there's risk to doing and risk to not doing something. And so it's about the risk manager has to feel comfortable with what kind of risk do they want to take on for the institution. So long answer, but this is very complicated, and it is rooted in the law. But I feel your pain, and again, I'm happy to help you offline if you'd like. And I've met and worked with individuals at Corewell, not where you are, but in Detroit, and I believe it was in the Grand Rapids area. So have a little bit of experience with that.
We do have about 5 minutes, so if there are other questions or comments that folks have, you have some time.
Monique, I would like to get in touch with you offline. Our hospital is trying to implement an opt-out strategy, and we're having a really hard time trying to navigate where we're beginning. We're thinking we want to start with certain demographics like STI testing and HIV users, not HIV users, I'm sorry, IV drug users. But I mean, we would love to get some of your ideas and just have a starting point and get some references or something, because we're kind of walking around in the dark and bumping into walls.
I'm happy to talk to you. Is it Sarah? And I think,
Yes, I'm from Muskegon, Trinity, Muskegon.
oh, nice to meet you. I think there's a Trinity Health partner in another state. I'm happy to talk with you offline. I think your idea, that's what a lot of some EDs are looking at. That's kind of what we consider low-hanging fruit, looking at the STI order set and seeing, well, how often, for example, when someone's screened for syphilis, are they also screened for HIV, maybe if they're diagnosed with syphilis? So is there an opportunity, if someone's coming in for a suspected or actual STI infection, they should be screened for HIV, which is an STI in some cases. So how much is that occurring, and what can we do to increase the amount of HIV testing that's occurring just in that population before we expand to the larger population? So I think your idea is a great one. Happy to talk with you and do some troubleshooting and see where you can go from there. And you have my email. We're going to send out the slides, but I'll pop my email in the chat as well.
Thank you so much.
No problem. I look forward to talking.
We probably have time for one more question if folks have any.
I know the afternoon is hard. People are like, okay, my day is over. I get it.
Well, certainly you got an email address from Monique. You've got an email address for the medic side, MHHS side with Sam. We're definitely here to support either way. And Monique, it was so great to hear about your program and again, all the expertise that you bring. And appreciate you sharing that with us. Just a reminder, Sam, if you can pop in the chat the survey link to complete this short survey, just to give us an understanding of our program impact. And then also just a reminder that the learning series continues. So our next webinar is in October, and we will communicate around that. We're going to hear from, I believe it's Corktown Health from Detroit about their experiences more on the linkage to care side of this equation. So please join us for that next webinar. And it's so awesome to see all of you, and please stay in touch. Thanks so much.